Hello and welcome. My name is Alice and I'm available to answer any technical questions. We encourage you to submit written questions at any time using the Q&A. Finally, during today's event, live closed captioning will be available in English and Spanish. You can find the link in the chat field. With that, I'd like to introduce Paula Fabaria, Chief Quality and Medical Officer and Deputy Director of the Quality and Population Health Management Division at DHCS.
Thank you all so much for joining us today for our CalAIM Population Health Management PNA webinar. We're really excited to showcase this policy, which came about through a lot of tremendous partnership with other state departments and our local colleagues. We can go to the next slide. So over the next hour, we are going to recap what progress we've made on our population needs assessment. We are also going to review our future state population needs assessment requirements for all Medi-Cal managed care plans over the next 3 years, and talk a little bit about the future forward state from 2028 onwards, and then review upcoming guidance and technical assistance, and then also hopefully allow ample time for a question and answer. I will give an early flag that we will not be covering SB 326 or behavioral health transformation elements of the population needs assessment today. We are still working through planning processes and stakeholder engagement for that. So please keep a lookout for future webinars and stakeholder efforts on that front forthcoming. We can go to the next slide. And so before we dig into the specifics, I will also just point out that we have an open chat. So all Sorry about that, everyone. Technical issues. I will point out that the chat is open and available for all of you to drop in comments, and your feedback is really welcome. We can go to the next slide. So to recap a little bit of where we are, so I think everyone has been tracking that as a part of our population health management program, which launched about 1.5 years ago now in January of 2023, we knew that we wanted to really refresh and update how our Medi-Cal managed care plans did their population needs assessment, which was a pre-existing requirement in our prior contracts and requirements. And consistent with the larger vision of CalAIM, we really do want to break down local silos and do a better job of integrating healthcare with other key partners at the local level, such as public health, social services, and others. And so one of the major opportunities as a part of this revision was to really think about how community health assessments and population needs assessments are done at the local level and really reduce silos and duplication that exist between how this process was done by Medi-Cal managed care plans and how this was done by local public health departments as a part of their community health assessment and community health improvement plan. Excitingly, this was already happening in some parts of the state, as you have all heard in our previous webinars, and to really be able to scale this best practice statewide is super exciting. And so last May, we released a concept paper. Many of you provided us with excellent feedback, which led to our APL being published last August, and Medi-Cal managed care plans submitted their first population health management strategy deliverable in October. And then we finalized our population needs assessment guidance in December, and then sort of the new approach for the population needs assessment kicks off starting this year. We can go to the next slide. So today we're going to do a little bit of a deeper dive onto what those new policy requirements are and what the landscape across the state is going to look like from 2024 to 2027. We can go to the next slide. So I think as we heard from many of you, especially in the public comment period to the PNA concept paper, one of the major barriers that really gets in the way of local collaboration today is that for the most part, the cycles for each local health jurisdiction for the CHA and CHIP are different. This has usually historically been tied to public health accreditation. So depending on when a local health jurisdiction was last accredited, the PNA or the community health assessment is done on a 3 or 5 year cycle. based off of accreditation. And so that start date varies by local health jurisdiction, and then some do 3 years and some do 5 years. And so for managed care plans, especially those that work in multiple local health jurisdictions, it can be really challenging to figure out how to partner on completely different cycles. It also becomes challenging at the state level to then use that process to inform other downstream deliverables, which we'll get to in a little bit. And so in really amazing, robust cross-state and local department collaboration, DHCS worked really intentionally with the California Department of Public Health, HCI, as well as our local public health representatives from both CHA and CCLHO to come up with a glide path to really get our entire state on the same cycle. And so from 2024 to 2027, we recognize everyone is still in these different cycles, and we're using that period as a ramp-up period for everyone to start figuring out how to collaborate, how to work together, how to speak the same language around population needs assessments and community health assessments, and then getting everyone aligned to be on a consistent statewide every 3-year cycle starting in 2028. So calendar year 2028 would be used for the actual health assessments. And then 6 months later, the first actual population health management strategy for the plans or a community health improvement plan for the local health jurisdictions would be due. And I will also flag that these timelines do align with similar deliverables for behavioral health transformation, which we'll talk about more at future meetings. And Trudy, if you're on, anything you want to add about this alignment process?
Hi. No, I mean, I think for all intents, what we have heard from stakeholders is that this really is a great move forward in terms of really connecting our public health and our healthcare system. We know and we acknowledge that working in isolation really just wasn't working. And certainly from the community perspective, this really does help to reduce much of the redundancy. It allows for more strategic use of resources and those kinds of things. So we are excited at this effort, and we're really excited to see where this goes for the future.
Thank you so much, Trudy, for jumping in. And for those of you who haven't had the pleasure of meeting Trudy, she's one of our colleagues at the California Department of Public Health that we work very closely with. We can go to the next slide. So to double click a little bit on what the requirements are. So obviously DHCS oversees our Medi-Cal managed care plans. So that is who these requirements apply to, and they were issued via our population health management policy guide. So first and foremost is really collaboration. So the prime plan, i.e. the Medi-Cal managed care plan that has the contract with DHCS, must participate in every local community health assessment for every local health jurisdiction in which they operate in their service area. So the 58 counties, plus I believe 3 other local health jurisdictions. For plans that are working in multiple counties, that does mean that they must participate in multiple CHAs and CHIPs. And the purpose of this is really to, customize and understand the local needs of each of the service areas that our plans operate in. The prime plan that is contracted with DHCS has to make sure that they are overseeing their subcontractors, and their subcontractors' populations are included in the process. But we, DHCS, don't require a whole separate submission for subcontractors. It's really the onus is on the prime plan that contracts with us to fulfill all of these requirements. We also heard loud and clear from many of the comments and in partnership with our public health colleagues that when there are multiple MCPs that operate in the same local health jurisdiction, it can be really administratively burdensome for the local public health department to have siloed conversations with each MCP. So the expectation is that MCPs have to collaborate with each other and public health in a unified planning process. There are not going to be, 6 different planning processes to cover each MCP. And then we also require in those multi-plan counties that the MCPs have to coordinate their investments so that it is shared and communicated, appropriately to LHJs. So again, those negotiations aren't happening in silos. We can go to the next slide. The second set of requirements is on what are MCPs bringing to the table. So we know, the MCPs used to invest resources and time and effort into doing population needs assessment. The goal and the desire of this unified process with public health is that both public health and managed care plans are sort of combining and sharing resources to do a more robust, meaningful, integrated community health assessment. And so all Medi-Cal managed care plans are required to contribute either funding directly and or in-kind staffing of various types to support the community health assessment process. The current year, 2024, is being used to figure out what those needs are, and then this funding and or in-kind staffing requirement goes into effect on January 1, 2025. And we have strongly encouraged plans to really think about this funding and or staffing requirement to be scaled proportionate to how much of the population they cover in that given local health jurisdiction. We know in some areas, a given plan may cover roughly 10% of the county. In other areas, that single plan may cover upwards of 50% of the county population. We also are requiring Medi-Cal managed care plans to describe to DHCF what types of resources and the amounts of those resources they're contributing, and we will be collecting all of that information via our annual population health management strategy deliverables submission. There are a lot more details in our policy guide, but some of the examples that are listed here really lift up the types of things that are needed for an effective community health assessment process. So there may need to be funding for administrative support, project management, consultants, data infrastructure, community engagement, supporting event planning for the community engagement, contracts with CBOs, or in-kind staffing as well with regards to any of those buckets or others. We can go to the next slide. The other bucket of requirements is data sharing. So I think we all recognize we are really trying to get to a data-driven future where we really leverage all of the information that we have collectively across the state to understand what local community needs are. And so between 2024 and 2027, Medi-Cal managed care plans are expected to begin sharing data with local health jurisdictions in ways that are needed to support the community health assessment and CHIP process. There's a list of bullets here that I won't read in detail about the types of priorities and data elements that may be helpful. Providing data analytics and analysis of that data may also be in scope depending on what the local health jurisdiction's needs are. And starting in Q2 of 2025 at the latest, MCPs have to actually be flowing this data in the agreed upon format to their local health jurisdiction partners. And so 2024, again, is more of a planning year to really understand what are the gaps, what is needed, how can both local health jurisdictions and Medi-Cal managed care plans leverage each other's strengths and assets when it comes to using a data-driven approach. We can go to the next slide. The next set of requirements is really around stakeholder engagement. And so, this is not just about checking a box. This is about true partnership and integration at the local level. So starting this past January, MCPs, as requested by the local health jurisdictions, should attend all key community health assessment meetings, serve on governance structures as requested. And then, as many of you are probably tracking, effective January 2024, as a part of the new Medi-Cal managed care contracts, all Medi-Cal managed care plans are required to have community advisory committees that are really comprised of community members and Medi-Cal members, and they are required to engage their community advisory committees as a part of this community health assessment approach. So those committees, there should be regular reports, they should be providing input and advice to the managed care plan on how to use the findings from the CHAs and the CHIPs. And then over time, we also want the LHJs to be able to leverage these community advisory committees, recognizing they're new this year, as a major source of stakeholder and community input. And then the local health jurisdictions already publish community health assessments and CHIPs on their websites, but the Medi-Cal managed care plans will also be publishing the CHAs and CHIPs for all of the local health jurisdictions they operate in on their websites, as well as sort of an explanation of how they will be leveraging this information in their own planning. We can go to the next slide. So there is a worksheet that we launched that the Medi-Cal managed care plans have to complete, which is really designed to see what sorts of local relationships there are, what direction everyone is headed in. And so the plans are working on these worksheets with LHJs. We are not sort of auditing, collecting them, but we will check on them if any concerns arise in the process to make sure everyone is on track. And then we will be soon issuing our population health management strategy deliverable template, which will be due back to DHCS in October of 2024. That is the annual submission, where we'll be doing a little bit of a deeper dive to understand how these local collaborations are progressing in preparation, especially for that sort of statewide aligned every 3-year effort in 2028. And then I will also say that for the MCPs that work in multiple counties, they only submit sort of one sheet to DHCS, one population health management strategy, but there is a breakout section for which they have to describe their collaboration and partnership for every single local health jurisdiction in which they operate. So for some of our plans, that is dozens of counties, but again, DHCS really does want to make sure that those partnerships are getting down truly to the local level and meeting the needs of each local Medi-Cal community. Go to the next slide. So as mentioned, in October, all of the Medi-Cal managed care plans will be submitting their population health management strategy deliverable to us. We are getting ready to release that template soon. And then for the 2024 strategy deliverable, specific things that we will be probing into, one is back in 2023, local health jurisdictions and MCPs, had in some cases their first meeting and we're starting to work on their collaboration, and they came up with SMART goals, i.e. quality improvement goals that they wanted to undertake together. They'll be sharing updates with DHCS on what progress they have made to that. They will also be sharing with DHCS how they are meaningfully participating in local community health assessments and CHIPs. And then they will also be attesting to completion of the NCQA population health management strategy and sharing updates to DHCS on progress towards their population health management key performance indicators and bold goals. We do want to know how this entire experience is working from multiple perspectives. So DHCS will be collecting the MCP data as I just described, and then our public health partners, CDPH, CHA, and CCLHO, will be soliciting feedback from local health jurisdictions. So any of you public health folks on the call, we really equally want your feedback as well, right? This only works if everyone is all in and working well together. So hearing about what your perspective has been on this process will be critical and taken into account as we make future improvements. We can go to the next slide. So as mentioned, we are going to be looking at all those deliverables. I think the other big thing, which we are still figuring out the budget situation given the state budget, but we are looking at the state level between both DHCS and CDPH, what opportunities we have to provide more meaningful local technical assistance. We know, again, in some counties, the managed care plans and local public health departments have been working together for years. They don't need us. In other counties, this relationship is much newer. And let's be honest, the language of public health and the language of healthcare and how we all approach the work can sometimes differ. And so we are exploring if there's ways to bring together plans and local health jurisdictions on a regional and statewide basis, both in person and virtually, to really help make sure that over the next few years, we are setting up every single local partnership for success. So more to come on that as we figure out the next steps. We'll go to the next slide. So I think we are at the Q&A portion. I will turn it over to my colleagues to flow questions up because I see the chat has been busy.
Thanks, Paula. I'll go ahead and throw the first one your way. Actually, though, you won't be surprised, and you actually preempted it by saying data sharing is, of course, a topic for many folks, strong interest. And you actually covered a little bit of this in a couple of the slides when you provided what the MCP is required to do through the funding, the in-kind staffing, and then the data sharing. So, but just to push those your way, one question was, what does MCP support look like? Our MCP has struggled to provide certain type of data, in this case, chronic disease, as an example, and then goes on to say, data sharing and working with MCPs on this seems to be an ongoing problem, and how will that be addressed? There's one more on data sharing, but let me stop there with those.
Perfect. So my first question would be, have you signed your MOU yet with your MCP, for the person who asked that question? So we know, right, data sharing doesn't happen by magic. It doesn't happen overnight. Part of this policy really was built upon the foundation that is being laid with the new Medi-Cal managed care contract. So effective 2024, all MCPs have to have memorandums of understanding with key local partners, and local health jurisdictions are on that list. And so DHCS, working closely with CDPH, already issued a boilerplate template for which both local health jurisdictions and MCPs could have an MOU, and there is data sharing language already baked into that to really help lay the sort of foundation for what that sharing of information can look like, and the legally binding agreement to do so. So that can be a good resource for any of you who are trying to figure out the data sharing. And that being said, obviously, if you are running into problems, you can always reach out to our CDPH colleagues or to DHCS, and we can help troubleshoot. But we know all of our plans have chronic disease information data on Medi-Cal members, and so that information should be available. We also didn't want to be overly prescriptive about what specific data elements, because we know the needs really vary from LHJ to LHJ. Different LHJs have different data capabilities, the local needs and sort of what conditions are of most concern are different across the state. So we did want to provide some flexibility, but really what is needed should be driven by our public health partners in this process, as they are the ones running the CHA.
Thanks so much, Paula. Just to finish the loop on data sharing, and maybe you answered this in there, I'm just not as familiar, but the question is, do the requirements align with the DSA data sharing requirements, and what is being done to achieve alignment?
Great question. And so, yes, both the MOU boilerplate template that I referenced, maybe someone from our DHCS team can drop the link to our MOU website, which has all those boilerplates on in the chat for reference, as well as the policy guide, specifically talk about having, the transmission of information align with the data exchange framework, which is what I believe you're referring to, as long as both parties are signatories. So there's very specific policy language on that front that you can reference.
Thanks, Paula. One more data question for you that just came in. What type of data are MCPs able to provide, and is this data available only by asking it via an MOU with the MCP, or is the data available online?
Great questions. And I will preface, you all know I'm not the data person at DHCS, right? We do have a chief data officer, but since I'm the person who's on deck today, our MCPs have a whole host of information on the Medi-Cal members they serve. And so for the most part, all services that an MCP pays for, they will have claims and encounter information that can be very useful for analytics to understand what healthcare utilization looks like. With those Medi-Cal members that MCP covers. They also receive a fair amount of information directly from DHCS about carve-out services like utilization of oral health services or behavioral health services that are provided outside of that. Many of them also get supplemental data or are hooked up to QHIOs to get more real-time information, such as admission, discharge, transfer, or other pieces of information. So obviously, all of that information is HIPAA protected, and so some of it can be shared in an aggregate, anonymized way, both publicly and with the plan, without a formal data sharing agreement, usually to get to more granular levels of data sharing, some sort of business associate agreement would be required. So it really depends on sort of what type of data you're looking for, in how much detail, that will determine what sort of agreement is needed.
A few questions on the LHJ side, Trudy, hoping you can answer those. The first, is there a single state link to see current LHJ plans? And then the second, are LHJs being required to do a CHA and CHIP even if they aren't going through PHAB?
Right. So let me start with the last one first. We actually did send out a memo to all of our local health departments. I think it was back in December of 2023, noticing them of CDPH's intent to go through a regulatory process to require that all local health departments do conduct a community health assessment and community health improvement plan. So, but it is not, we are not requiring them to be accredited, but that they do a community health assessment and community health improvement. And it matches the timeline that Pallav shared within her presentation. So that requirement would go into effect with the CHA being completed by 2028, and then the subsequent CHIP being completed by June of 29. And I can share the link to that memo in the chat. I think the other piece is, are there community health assessments or plans like centralized in one place? Was that the question?
Yes.
There is not, unfortunately. So if you are an MCP, I would highly encourage you for the local health departments or local health jurisdictions that have done a community health assessment and community health improvement plans, those should probably be on their website. So I would take a look at those individual county websites to see if they posted it. The one caveat I do want to say is that going through accreditation or community health assessment, community health improvement is not currently a requirement for LHJs. So it may not be available simply because they have not gone through that process yet. But that is one of the reasons, I'm really excited about this work, is it's not just kind of setting a statewide, I think, synchronized plan for going through these assessments, but we're really working in concert to say, these are important things that both the local health jurisdiction as well as the MCPs need to do. And so hence why we worked very closely on issuing that memo to the LHJs, letting them know that we do intend in the future to go through that regulatory process to require a CHA and CHIP of the local health department.
Thanks, Judy. We have one question on MOUs that just came in as well. Is an MOU only required to be established between an MCP and DHCS, or an MCP and LHJ?
Sorry, Liz, tech issues. Can you repeat that one more time?
No problem. The question is an MOU only required to be established between an MCP and DHCS, or MCP and LHJ?
So as a part of the 2024 managed care contract, which is the relationship DHCS has with each of its Medi-Cal managed care plans, the managed care plans have to have MOUs with all of the local health jurisdictions in which they operate. So I know many have already submitted them to DHCS. I think there's still some in the works, but it's between the MCP and the LHJ is that MOU requirement.
Thanks, Paula.
Paula, we have one next regarding the overlap with community reinvestment. Will these P&As inform MCPs how they'll need to invest any future community reinvestment funds, similar to how CHNAs inform hospitals?
I was hoping someone was going to ask this question. So the short answer is yes. We have not actually issued the community reinvestment policy yet. There is high-level language that is in the Medi-Cal managed care contracts. We are aiming to get a draft all-plan letter out for public comment over the summer, which will then go through the public comment period and be finalized as the first sort of formal policy that is issued on community reinvestment. But the short answer is yes, we do want community reinvestment to be guided by local needs and local gaps in healthcare. And so the findings from this joint P&A community health assessment should inform what types of activities the community reinvestment is used for. So more to come, and keep a lookout for our draft APL.
Thanks, Paula. A few questions for you, Trudy. Sorry to be jumping around here. One is the exact due date of the realigned triannual LHJ CHA December 31st, 2028?
Yeah, that is when they will be due. So that will be the last date for the LHJ CHA. And then 6 months later, by June of 2029, will be the Community Health Improvement Plan, or the CHIP.
Thank you, thank you. And the next one for you, Trudy, is that DHCS requires MCPs to collaborate with LHJs on the CHA and CHIP. Does CDPH have the same requirement for the LHJs to collaborate with MCPs?
We are certainly, we want to make sure that during this glide path, during 2024 and 2027, we are strongly encouraging all of our LHJs to start to build that relationship now and start those conversations, really thinking through what that relationship can look like, looking how to kind of think about resources strategically in order to achieve that CHA and CHIP process, really just so that they are best suited and best prepared to meet that requirement in 2028. And so we have been strongly messaging that to all of our local health department leadership.
Thanks, Trudy. And then one more for you in both Paula's is we gotten a few questions on nonprofit hospital community health needs assessment and how that relates to the LHJ CHA requirement.
I can start. I think there are actually several of our local health departments that are currently working with their not-for-profit hospitals because we know for many of them, you know, it makes sense in their community to have all of those sectors aligned. So there are some really great examples where that's already working. But I will turn it over to Pallav to talk about kind of some of our conversations around the requirement for nonprofit hospitals.
Yeah, absolutely. So as Trudy pointed to, we know that this type of collaboration is happening locally today where nonprofits are also coming to the table. So, highly encourage that locally, that if your nonprofit hospitals are not involved in your joint P&A CHA process, it's a great opportunity for increased alignment. From a pure authority standpoint, the requirement on nonprofit hospitals and their community benefit plans is a federal requirement, not state. And so, that sort of requiring them to do it would definitely be outside of both CDPH and DHCS's authority. That being said, our HCI partners who do get reports on the nonprofit hospitals, community health needs assessment activities, and community benefit programs have been involved in this statewide planning process. And I think we can also, if we can dig them up, drop the link to the proposed regulations that HCI released recently on reporting requirements. And they are interested in learning about how nonprofit hospitals are involved with local health jurisdiction and MCP, P&A, and CHA efforts, but there's no authority to require them to do so today.
And then one clarification question on the shared goal / SMART objective activity that was in last year's PHM strategy for DHCS. We have a slide on that, Paul, if you'd like to bring it up as well. So
yeah, that sounds great. So we've gotten a lot of questions. So glad someone asked this, and hopefully this will clarify. So before we issued this new guidance for 2024 last year, our goal was, can MCPs and local health jurisdictions just start building a relationship if they don't already have one? And we recognize that DHCS's Bold Goals initiative really is designed to improve children's preventative care, maternity outcomes, and behavioral health, as well as close racial and ethnic disparities in those spaces. We know from our conversations with both local and state partners that those are all objectives that for the most part are also bodies of work that our local public health partners are working on. And so the plans were required to meet with their local health jurisdiction partners and think through, is there a shared SMART objective or quality improvement project that you both can work on together that sort of aligns with what public health is doing and what the plans are already doing in this domain that you can work on over the next year until this new formal policy guidance is done. And so in 2023, plans submitted essentially like a 12-month plan for this SMART objective. Some of our plans are done with that objective already. Some are still working on it. They will be updating us this October. What happened over the last year? You said you were going to do this. Did anything happen? Did it not? But after that one-time sort of interim phase, moving forward, there is no requirement that the local health jurisdiction community health assessment process or the CHIP must align with the Bold Goals. That was a one-time sort of collaborative project. Obviously, if you find common ground and you want to focus on the Bold Goals, DHCS loves that because we are committed to making these goals a reality, but there's no requirement to do so.
Thanks, Paula. All right. We have one question here. This could be for both you and Trudy. Could you review where collaboration between the MCPs and LHJs have been in place for a long time?
What was the question again, Liz? You were breaking up.
Oh, sorry about that. Technical difficulties on my end too. Could you review the collaboration could you review where collaboration has been in place for a long time between MCPs and LHJs?
Well, I mean, I think there historically has been collaboration between MCPs and LHJs, and I think in some jurisdictions, certainly that has been much stronger than in others. What we're really hoping to do, over the course of these next couple of years is really strengthen that. I think one of the greatest things that I've seen is a lot of the shared messaging that we are now doing along with DHCS, because we know this level of collaboration is really going to be important and critical. So as to get, I think, these two sectors that once worked in isolation really to start working together, because I think we realize that that's really the best way to start showing impact in our communities and really start to think about more strategically how we move some of these things forward. So there hasn't been necessarily a requirement per se around a level of collaboration other than I think a historical MOU, which I will leave to Paula to confirm. But, again, during this period, one of the things that I think we are excited about is seeing a much more intentional level of collaboration between our MCP and public health department colleagues.
Thanks, Trudy. Over to you, shall we?
Yes, I wasn't sure that Paula, if there was a question in there for Paula, and I couldn't tell if maybe Paula froze, so she might be having a technical problem. Paula, are you okay there?
Yes, no, I totally agree with everything that Trudy is saying. We saw, even if this foundation, was more robust in some areas than others, really over the public health emergency, I would say it's fair to say across the entire state, MCPs and local health jurisdictions, work together in an unprecedented way. And I think we are really, through some of these more formalized policy mechanisms, really looking to build upon a lot of those local partnerships that were already built. And then to whoever asked that question, if you're specifically looking for bright spots on the PNA and community health assessment, specifically, I think we had, Trudy, keep me honest, I think it's San Joaquin County has had a really robust, over 10-year collaboration where the health plan and local public health and all the nonprofit hospitals in their region have been doing a joint CHA. So I'm sure Barb wouldn't mind you reaching out to them for tips and advice.
And if the question was coming from an LHJ, feel free to reach out to me. We've got some great examples, as well as examples for jurisdictions that have actually been working in a 3-year cycle. Because we know typically for accreditation, it is a 5-year cycle, and we are now moving to a synchronized 3-year cycle. So we've got some great examples also of folks that have already been working in a 3-year cycle.
Okay, thank you. We're going to change course just a little bit and go back to Paula here. In behavioral health, we've used DHCS estimates on the prevalence of SMI and substance abuse problems in our county. Some of these data have not been updated recently. Is there a plan to have a uniform source for the prevalence of certain behavioral health conditions in communities?
Really appreciate the question. Can't commit to anything, but it's definitely a need that we recognize and something that we are looking at for all of the other behavioral health initiatives that are happening across the state. So can take that feedback back for sure.
Thank you, Paula. My partner in crime, Liz, also is having technical problems. So now I'm going to try to facilitate single-handedly here. We'll see how I do. Okay, got a couple more questions on the PHM strategy. Let's see. One of them is regarding the timeline for providing the template for the PHM strategy deliverable that is due October 31st of this year?
We definitely committed to providing it this summer and are hoping, I think I'm the bottleneck. I take responsibility on that one. My team has done their due diligence, and so we should be hopefully getting it out pretty soon.
Great, thank you, Pallav. And then another on the strategy, let me go back and find it, I'm sorry. A couple on the SMART goals and KPIs. So let's see, wanted more clarification. Are the SMART goal objectives and the CHA chip resources funding two different things?
Short answer is yes. So the SMART goal objective was something that was on a piece of paper that plans filled out last year and submitted to DHCS in October, which was again this sort of 1 year community quality improvement sort of SMART goal project to be done between the LHJ and the plan. The resources for the actual CHA process, the planning should be happening in 2024, and then per the policy guide, those resources should be going to the local health jurisdiction effective January 1, 2025.
Thank you. We're getting to the end here, Pallav, so that's great. Let's see. Does MCP include county MHPs in terms of collaboration with PNAs?
If you ask that question, maybe you can help us clarify. So we do have county-owned health plans, COES model health plans. So yes, all Medi-Cal managed care plans provide Medi-Cal services and have a contract with DHCS are included. If you meant county behavioral health plans, which are our DMC, ODS, and mental health plans, they will be participating in some way in the PNA as described in Prop 1 and behavioral health transformation, but that planning process is just kicking off now. So no specific policy guidance has been issued around county behavioral health involvement at this time. But Medi-Cal managed care plans, including local initiatives, and the COES are subject to these standards we've been talking about. Okay, great. Yeah, and I think our question person clarified, they were talking about county mental health plans. So yes, more to come on county DMC, ODS, and mental health plans in the forthcoming months.
Well, great job. Great job, Pallav. Besides getting through all the slides, you have successfully answered all of the questions. Are there any additional questions at this time? Pallav, not seeing any at this time. Oh, something just came into the chat. Will there be guidance / collaborations on how to collect data on justice-involved populations? This can be difficult to track given barriers to accessing information from corrections facilities and engaging with justice-involved individuals.
The short answer is yes. As a part of DHCS's justice-involved work for both pre-release and post-release services, there's a number of work streams underway right now to figure out exactly that, like how do we identify everyone who's incarcerated, who's eligible for new Medi-Cal services as a part of the JI initiative, and Medi-Cal managed care plans will also be a part of that conversation as pre-release services start to go live across the state. So lots more to come on justice. And hopefully our plans will be able to bring more of that information to the table, as well as the state contributing additional information in that arena as well.
Thank you, Pallav.
And I see in the chat, yes,
yeah,
thank you, Ventura County. We really appreciate you jumping in. Another bright spot, it sounds like, where local entities have figured out how to work together. So we really do hope to get that additional technical assistance off the ground in the next year or so to really be able to scale and spread some of these best practices that are clearly already happening in our state.
And that does conclude all the questions at this time, Pallav.
Well, I'll just say this may be our first webinar that we've ever finished early. So I don't know if that just means everything is really clear or people got bored and it's a Monday. But thank you all so much for joining us today. And I know I speak for both, myself and Trudy, that CDPH and DHCS are really excited to support this integration and collaboration at the local level. And just, as you all run into barriers or get stuck or need help, please feel free to reach out to either one of our departments, and we will help troubleshoot. Thank you all. Have a great day.
Thank you all.